Um, uh, I'm not very sure about the details of your experience. Oh, okay, there they are.
So that's okay, sir. You should get on with the task of the day.
Well, I completely agree that it should be only meat and not much gravy.
Right.
So all yours.
Thank you, sir. Can you put on my slide? So for the residents, before we begin, I was asked to talk on the advances in diagnosis and management of nephrotic syndrome in children, but I'm well aware that for residents it might be challenging to know what to manage pediatric nephrotic syndrome as. So please feel free to ask for my slides later and just listen to this talk, because for the faculty this is familiar terrain, for you it may not be so, and I'll need to go through the approach to management as well as the advances. So without much ado, let's just begin. Nephrotic syndrome in childhood tends to begin between 2 to 5 years of age. Children present with edema, puffiness around the eyes, followed by rest of the body. They would have low serum albumin and heavy proteinuria in the nephrotic range. It's a rare disease by definition. If you look at these incidence and prevalence estimates. Majority of patients who begin within 2 to 5 years, and the disease goes on through childhood up to say 10 to 15 years, sometimes into adolescence, and rarely relapsing also into adulthood. Half of them would have infrequent relapses or just one single episode, but almost half of them, at least in the South Asian setup, would have frequent relapses or steroid dependence. These are the definitions we use, and just for reading's sake, Indian Pediatrics 2021 May and July sessions would carry updates of the guidelines of the Indian Society of Pediatric Nephrology, where these things are defined and dealt with better. So steroid-sensitive nephrotic syndrome is the child response to steroids within 6 weeks of starting of therapy. The child, once he gets into remission, complete remission with steroids, afterwards if the disease comes back, it's a relapse. If the disease relapses twice in the first 6 months, it's frequent relapses, or for 3 times in any subsequent year, it's frequent relapses. If the child is relapsing the moment he makes it alternate steroid dependence, but it should not be just by chance once, but more than once. And steroid resistance is defined as not having responded completely to steroids at the end of 6 weeks. Now, this is different from how you deal with the disease in adults. I know that. Now, the problem is that we still don't understand, despite say 6 decades of research, what causes nephrotic syndrome. And we really know that probably we are like 7 blind men dealing with an elephant. One person talks about one pathogenesis, one pathophysiology, the other talks about another, and the other talks about another. And literally that's how it is. There's a group of researchers who talk about it beginning with the naive immunity. A viral trigger happens, naive cells are upregulated, maybe it's a cytokine release which acts on the toll-like receptors on the podocytes, and this causes proteinuria. Some talk about a T helper imbalance, Th2 upregulated, Th1 downregulated. Others talk about Th17 upregulation versus T regulatory downregulation. Then there is a group of researchers beginning since 2014 who talk about autoantibodies in nephrotic syndrome, the latest example of which is anti-nephrin antibodies for the last 2 years. There have been talks about podocytes CD8 upregulation leading to CD8-uria, and there's a whole panel of entities called circulating factors which I'll just come to. Now these are all just the immune part of stuff. There is also a monogenetic bracket of disease in nephrotic syndrome, which we are again deciding on who to talk about in that. So this is probably a set of patients who either have a circulating factor or immune disease, or they have a genetic disease. Now who is what? Let's just go over and see. Steroid-resistant nephrotic syndrome, there have been lots of work on which talk about various kinds of circulating factors. How do we know about this? The best clinical example is that of a case long back, several decades back, which was reported, in which a patient of FSGS received an allograft from a healthy person. The disease recurred within minutes, and then they explanted that graft and put it into another recipient, and the kidney functioned fine, which indicates that the first recipient had some circulating factor caused the proteinuria. And there's been plenty of example in experimental evidence that indicates support for a circulating factor in patients. There have been variety of circulating factors that have been outlined here, as you can see. And, literally we don't know which is the right one, and probably none of them is the right one. We do know that there have been assays such as circulating factor permeability assay that have been developed in certain Western labs that measure permeability of rat glomeruli, for example. But we still don't know what is it. Overall, we know that the disease has 2 brackets. Either it's a circulating factor disease or it is a monogenetic disease. And identifying which is important, particularly if the patient progresses to end-stage kidney failure, because the circulating factor disease, which should have responded to immunosuppression and did not, is likely to recur after transplantation, and you need to monitor for it and treat it. On the other hand, a genetic disease would not benefit from immunosuppression. You would rather not give immunosuppression because these are also toxic, and you would wait for them to progress and then be certain that it would not recur after transplantation. But you need to select your donors carefully. Anti-nephrin antibody is the latest among advances. It's the latest circulating factor to be put up there on the chalkboard as the putative circulating factor of importance, particularly in minimal change disease of childhood. There was this initial report in 2022 November which talked about it, and it indicated that 1/3 of patients would have autoantibodies to nephrin. And how did this begin? You have patients with United Nephrotic syndrome who probably have a problem of nephrin deletion, some of them, the Finnish variety, the Finn major variety. And those patients, after transplant, since the body never had nephrin in their system, they might develop autoantibodies to nephrin, and they presented something like a nephritic syndrome with hematuria, proteinuria, etc. That's the background on which this has been studied, but definitely this is not nephritic syndrome, this is nephrotic syndrome that people are talking about. Something like membranous nephropathy, which is now understood to be a renal-limited autoimmunity. So they have demonstrated by confocal microscopy that not only do these antibodies exist, but they also probably bind to the right location on the glomerular podocyte. This is indicated by the confocal microscopy here. So subsequently, in the last 2 years, there has been abundance of papers, almost 6 papers, including the latest NEJM report in May 2024, which in a large group of researchers have put together their resources from multiple centers in 357 adults and 182 children, and suggested that almost half of patients with minimal change disease and 1/10 of patients with FSGS might have circulating autoantibodies to nephrin, particularly so in childhood onset disease, which is naive to immunosuppression. But there are more coming up, it seems. In another issue of the KI reports, it indicates that there are probably split diaphragm antibodies. So what is all this? I mean, there's one 10-year-old paper that talks about a panel of 7 autoantibodies that can be used to detect nephrotic syndrome. But are we there already? Have we found the holy grail of nephrotic syndrome here? We don't know, because a similar situation was there about 15 years back when SUPAR was mutated as the soluble factor for nephrotic syndrome. And as fast as it goes into importance, people even going on to talking about SUPAR-X as the filter for SUPAR to erase out the circulating factor, it went down quickly as well in 2014, with multiple reports indicating simultaneously, including from our center, that SUPAR is probably upregulated with inflammation and with impaired kidney function, and not so with nephrotic state. And there it went down the drain. So we don't know what's the fate of anti-nephrin antibodies. Let's see it repeated in non-Caucasian cohorts before we can say that this is it. There's been some work on other domains of immunology, including microRNAs in nephrotic syndrome, and this is one recent work from our center wherein we found multiple microRNAs upregulated or downregulated in steroid system in nephrotic syndrome and steroid-resistant nephrotic syndrome. Still, this part is not settled yet as to what is the immune basis of disease. What about the monogenetic basis of disease in nephrotic syndrome? Monogenic steroid resistance, beginning with nephrin being described for nephrotic syndrome, we've come down in 30-40 years to almost 100 genes being implicated in the causality of nephrotic syndrome in different domains of the podocyte, as you can make out. And all of these are important in different contexts. Some would be associated with syndromic forms, some would be sporadic, and they would have different phenotypes as well. Congenital nephrotic syndrome, thankfully, is a simple entity. Less than 3 months old onset of nephrotic syndrome, you must always think of it as monogenetic disease and therefore not use immunosuppression there. Below 3 months age of onset, do offer genetics there because that will have implications for subsequent pregnancies as well. And kidney biopsy is not helpful because it's only going to give you a tissue diagnosis but not give you a genetic diagnosis. These are the genes implicated. Majority of worldwide series would report NPHS1 as the causative pathway gene, and the others in the blue are the more common ones that are implicated. And almost 80 to 90% of cases in nephrotic syndrome would have a genetic basis. What about India? When we looked at the Indian subset of patients, this was published in Indian Pediatrics with IGA collaboration where we did this, almost 85% had a genetic basis, and this was more or less NPHS1. And we had 3 mutations that were the most common mutations in our setup: 2600, 109, 3478, and their PLC, OSCHEP, etc. were other entities. What about steroid resistance in general, not the congenital one? What is the prevalence of monogenetic disease there? When people have looked at data coming from research labs where samples were sent over the last 2 to 3 decades, people have found a genetic basis of disease in 24 to 30% of cases. However, this is more so data which is populated by Caucasian subsets. There is also data that is overpopulated and overrepresentation of the non-response cases. Because why would I, sitting in New Delhi, send a sample to Dr. Hildebrandt lab in Boston? I would send it because the patient is not responding. So probably enriched cohorts of non-response patients in which this data is coming from, and therefore probably this is an overrepresentation. Detection rates obviously vary by rates of consanguinity across the world, but one thing is very clear: monogenetic disease would not respond to immunosuppression. If you look at the Kaplan-Meier estimates, the time to kidney failure is rather rapid for the patients with monogenetic disease and those with non-response to immunosuppression versus the ones without genetic disease or with response do well on the long term. However, there is some meta-analysis that suggests that maybe a subset respond. However, we worry that that is probably not very well phenotyped cohort of patients. Maybe the response was not that sturdy. Overall, when we put together this data from large cohorts, we felt that the odds of having non-response to genetic disease was fourfold, and the odds of having kidney failure was threefold in patients with genetic disease. So it's important to diagnose. You do need to worry about them because they will not respond to immunosuppression, they will progress to kidney failure. You would have implications around transplant and donor selection, as well as in prenatal testing for subsequent pregnancies and siblings and etc. Overall, what it seems is that while the prior data suggests 25% data, if you look at more data coming from Asia, the Dragon Network, and from China, the rates have been very variable and different genes have been reported. More or less, the UK data, Japan data that recently come suggest more like 10 to 15%, not 25 to 30%. And similarly, experience from our center, this is again DBT supported and IGA collaboration pediatric renal biology program data, this is under review. And here we found in all cases you would have about 24%, but if you were to filter down by the risk factor to only sporadic cases, not the infantile, not the non-response, not the ones with family history, not syndromic, then it's only nothing. I mean, sporadic without any such context, no rates of genetic basis. So this is a thing that we need to decide who to study for genetic basis. What about steroid sensitive disease? Obviously, we all have families with nephrotic syndrome in which two siblings are affected, but it's really much less common than autosomal recessive, more like 1%. And therefore, people have looked at HLA, polymorphisms, and they have found that there are various risk factors in HLA class 1 and class 2 loci in steroid-sensitive patients all across different ethnicities. And there are other podocyte genes that have also been implicated, but these need further study. Maybe they modulate the immune system in some way. So I'll stop here with just telling you what we need to do. So you have a kid with nephrotic syndrome. How do you evaluate them? Standard material would be to look for nephrotic proteinuria. You need to document that there is edema, at least at the first instance, and there must be low serum albumin. Kidney function should be normal, complete blood count should be fine. The urine sediment should be bland. If you have RBCs persisting, that should ring a bell about a glomerulonephritis going on or a hereditary podocytopathy such as Alport syndrome going on. So these are the standard tests that you would do. Tuberculin test is not really mandatory if you don't have a context. And certainly you don't need to do other tests unless there's a context. So you don't need to look for CT and ANA in every child of nephrotic syndrome. Kidney biopsy is not required in children because majority of children will have steroid sensitive disease. Steroid resistance would be requiring a biopsy, and we'll come to that. What about indications for kidney biopsy? Finally, therefore, so a child with standard variety nephrotic syndrome would not merit a biopsy, but someone presenting with raw hematuria or having persistent microscopic hematuria, a low C3, very severe hypertension, systemic features suggesting lupus or IGA vasculitis, you would want to biopsy them. Definitely, the child goes on to have steroid resistance, you would biopsy them. And in context of therapy with CNI, if you have prolonged CNI happening, there you would want to biopsy because creatinine is insufficient to detect CNI toxicity. Steroid resistance, how do you define? I just told you that steroid sensitive disease is that which responds completely within 6 weeks. So at the end of 6 weeks, if you have 1+, 2+ proteinuria lingering or 3+, 4+ happening, that is definitely steroid resistant. Previously, this definition was at 4 weeks, but we do have patients respond in the next 2 weeks. Also, to meet that initial therapy, to have consensus around that, you would be 6 weeks is a easy thing to remember for everyone. Certainly, adults and children have different timelines of response, as you are well aware. So what do you do in a child with steroid-resistant nephrotic syndrome? You would biopsy them, you would quantify their proteinuria, you would do the complete kind of evaluation of knowing where you are sitting with the GFR just by looking at creatinine and using a modified Schwartz. You would want to rule out chronic viral infections because you're going to use intense immunosuppression afterwards. Genetics, only a subset would require. We would limit genetics in the Indian context to patients with a genetic nephrotic syndrome. Infantile onset of steroid resistance is one category that you would want to do it in. Patients who do not respond to CNI, who have syndromic features, a family history of steroid resistance, and before transplantation. we would want to do genetics in these contexts, which are the useful contexts of doing genetics. How do you do it? You prefer an extend panel covering all the 90 plus genes that are reported for steroidosis and Podocytopathy syndrome, and every year you have 3-4 genes getting added to these lists. You would do Sanger sequencing sometimes when you're testing siblings or donors, etc. And those contexts are also defined. So all this is defined in our guidelines in July 2021 in Indian Pediatrics. To come back to how to manage nephrotic syndrome. Now we know it's a simple disease, simple enough disease really. The disease relapses, response to steroids, comes back again after a while, response to steroids. So why worry so much? We worry because while many children would get better over the years, as shown in this graph, most children would get better over the years. The worry is around steroid toxicity, and the worry is around the severe relapses, which can have life-threatening consequences and complications. And some of these are just listed on this slide. So, what can we do differently to prevent frequent relapses from happening? Obviously, there are certain risk factors like young age, which predisposes to frequent relapses, which you can't change. But you can probably intensify your initial immunosuppression, and maybe that will make things different for the future in terms of frequent relapses. Based on that premise, many studies happened in the 1980s and 90s, which said that yes, extending initial therapy is indeed useful, based on which the Cochrane concluded that please use longer therapies so that frequent relapses do not happen later. However, this changed afterwards. Why it changed was because of 4 large multi-center placebo-controlled trials, which happened in India, in Japan, in Netherlands, and UK between 2013 and 2019. They were published, and they changed everything. Cochrane changed its stand, and it made sure that based on this low risk of bias studies, initial therapy should be limited to 4 to 6 weeks of daily therapy, followed by 4 to 6 weeks of alternative therapy. There is no definite advantage of prolonging therapy beyond that period of time, and that's how our guidelines say 6 weeks daily and 6 weeks alternative. There's a conflict around dose by meter square and by kilograms, which I have not talked about, but we dose young children by meter square because the surface area is out of proportion to the weight. What about young children? There is some data to suggest in 2 of those studies that extended therapy might be better in those children, less than 4 years, less than 6 years, in the UK study and Indian study. However, when we repeated the study in young children, and this is just under publication again, it indicates that there is no legacy effect. Do you understand the legacy effect? You give steroids now, will it change the course for later? It does not. You might postpone the first relapse because you're giving steroids for longer, but nothing happens afterwards. You still tend to be frequently relapsing if you're destined to be. Similarly, people have used different medications like cyclosporin at the onset, MMF, levamisole, and now rituximab even. All of this data seems to suggest that first relapse goes later, probably nothing much lasts forever. Why are we worried around steroids also for the initial episode giving extended is because of the steroid side effects. We don't want to keep on adding toxicity based on just giving steroids. And this is a long disease, a decade-long disease, so many times we have to use steroids. And each kilogram of steroid has its consequences in terms of increasing odds of all these complications. So, for the relapses, people have been working out whether we can do the things differently because the disease relapses will keep happening. Can you treat it with shorter courses and smaller doses? And multiple studies, non-prospective studies, retrospective studies have been carried out. 2 large RCTs are going on currently in the Netherlands and in India, which are multicentric placebo controlled. And that data will determine whether we can really go shorter or smaller on therapy of relapses. For the moment, we stick by this. Daily steroids until remission, 2 mg per kg or 60 per meter square, and 40 per meter square or 1.5 mg per kg for 4 weeks, and then stop there for infrequently relapsing disease. But this might change in a few years. How do you define frequent relapses, and why do you worry about frequent relapses? I told you about toxicities and I told you about complications. We don't want them to happen. So we need to define them that this is a child who is relapsing frequently. Do something to stop him from relapsing frequently. And how do we define? Definitions were incongruent in the past. Everybody now kind of agrees that 2 relapses in 6 months and 3 relapses in a year are too many relapses happening. Call that child as frequent relapses. Do something about it. Now, what do we do something? It might seem ironical, but we do something in terms of giving steroids, but in a tapering and a low-dose manner. Why is this still not bad as in terms of steroid? It's because it's a low-dose steroid, and if you add up the exposure over a year, that exposure is much lower than if you were to treat relapses separately. Also, there are various postulations. I mean, infections are the triggers. If you were to make the steroid daily during that time, that helps, and there is enough data to support that, although a recent UK study does argue against it. So our first step in a child who does not have steroid toxicity without adding a second medication would be to use low dose long-term steroids and give it for about 12 to 18 months, slightly step down after a year, and then discontinue it and make the dose daily during infections. Other medications are all listed here. They are there in the guidelines. I'll not bore you to death with details about them, also in the interest of time. They all have their consequences. They all have their monitoring profiles that you need to know about. I'll just show you these two algorithms. The IGA algorithm, the International Pediatric Nephrology Association algorithm, which says you have a bouquet choice of medications, use what you like. On the other hand, we have tried to define it better for the Indian population. We say that to start out with alternative steroids if there is no toxicity and if the child tolerates that. If the child is too frequently relapsing with develops toxicity, choose these medications based on your threshold, based on the severity of relapses, based on whether there are any features of toxicity, etc. You make these choices. So we use levamisole and MMF first, then we go on to cyclophosphamide, then we go on to CNI, and we reserve rituximab only for those who really merit the use of such agents. So I'll switch gears now to steroid resistance. So I talked about how we define steroid resistance, and I'll talk to you about how, when we treat steroid-resistant nephrotic syndrome, we define the response. In steroid-sensitive nephrotic syndrome, it's very simple. The parents maintain a diary. The protein goes away entirely, completely. In resistance, the protein may not go away entirely. It may stay lingering at a small amount. And we define partial remission and complete remission differently than in adults. Again, this is there in definitions in the guidelines, and you can go over them. But why do we need to define these? We need to define these because the three categories, complete response, partial response, and non-response, behave differently on the long terms in terms of their risk of kidney failure. And that's why you need to know, and that's why you need to achieve complete remission or at least partial remission so that you can keep them well on the long term. And that outcome is defined usually at 6 months of therapy with that agent, whichever agent you choose. Now, which agent do you choose? Again, over time, lots of agents have been tried, starting from pulse corticosteroids to oral cyclophosphamide-based Mendoza regimens to calcium inhibitors coming on and showing that this is the drug of choice, to add-on agents such as rituximab in refractory cases, and more recently other therapies, immunomodulators, etc. But overall, CNI are the standard of care. This is based on RCT data that I just put together this slide. You can see that tacrolimus or cyclosporin, either CNI would be the most useful agent to use in steroid resistance. Other agents are clearly inferior, and there is enough RCT evidence to say that you have to use this as the first medication. Obviously, you add on an ACE inhibitor to achieve further reduction of proteinuria in non-immunosuppressive manner. So, reduction begins by 4 weeks, median time to response is 3 months, and by 6 months, someone's not turning around, not partial remission yet. You probably need to think of another line of management. So, you know these standard policies, about AKI and other things that we need to monitor. We do that for the adult world as well. But what if CNI do not make an impact? What do you do then? Really, we don't have any great choices. All of the rest of evidence is not very great, and we use some of these poisons. So we can use rituximab as an add-on to CNI, or you can add on MMF to CNI. Do remember that adding immunosuppression in a child who's edematus anyway would probably risk more toxicity as well as infections, etc. You have to be careful around all that. And these are children, And then there are other medications that have been tried and been given up, like ACTH, abatacept, adalimumab. Something that's come to stay and linger is LDL apheresis. And there is some data that I'll talk to you about with that. But what if a child responded to CNI? What do you do next? You give the therapy for a while, but then you are risking toxicity on the kidney. Beyond 2 to 3 years, you are again very worried what to do about this child. So then you want to either stop or you want to switch. Because if you stop, you might risk relapses. If you switch, what happens? When we did an early switch to MMF at 6 months, we found it not useful. It's too early to switch. What about switching later? We are examining that right now. And what about rituximab in that context? So rituximab has turned out to be a very, very useful way to switch away from CNI in a child who's relapsing even on CNI. And rituximab shows good profile on this, getting off steroids and CNI, but the disease relapses after 6 to 8 months or sometimes 12 months. So we need to have strategies for that. So this is our algorithm for steroid resistance, the Indian guidelines. You do some baseline evaluations. In suspected monogenic, you abandon immunosuppression if you find a monogenic cause. And if you don't have genetics indicated or you have a non-genetic disease in those indicated, you try a CNI with ACE inhibitors and alternative steroids. If the CNI works out very well with complete response, no relapses, you take it off after 2 to 3 years. If it doesn't work out very well, it's continuing to relapse, probably switch to another agent like rituximab or MMF. If it is not responding to CNI, then you need to add on some immunosuppression, and the choices are really few. And also consider genetics and vaccines. What about rituximab? Rituximab, I just wanted to dwell on for a bit more because I thought that this would be an important agent to cover when you're talking of advances in nephrotic syndrome management, because this has come to stay since the first reports in 2005 to 2007, and certainly RCT evidence is enough to indicate that in frequently relapsing disease it's a useful agent because it helps you get off steroids, it helps you get off other immunosuppression. But remission lasts variably between 9 to 18 months, and then what? What do you do? Another problem is many kids could have infusion reactions, and then there are other problems as well. How does rituximab act? Now, conventionally, more or less, people think it's a T-cell disease that you're dealing with, and then you're giving a B-cell depleting agent. What's happening here? So probably there's some T and B crosstalk that's being changed by use of rituximab. There is evidence of T helper T regulatory upregulation. There is evidence that there is probably changes in the podocyte CD8T expression and so on. Some of this work is happening in Italy, some of this is in India, etc. But whatever you do, after the B cells are back, after a variable length of time, not just when the B cells come back, but maybe when the memory B cell comes back, then the disease comes back again. What can you do to prevent that? You can probably try one of these things, wait for the disease to relapse, give rituximab again, or you preemptively give more rituximab, or you preemptively add an agent such as NM. These strategies have been tried and with different outcomes. Overall, we feel that at the beginning we should give 2 doses and wait it out rather than add NMS or use 1 dose, because 1 dose would probably have a different pharmacokinetics and the disease will relapse faster. Since 2015 at our center, we've been using sequential therapy in those in whom we can monitor it properly, and we would, in the steroid sensitive kids, redose at about a year's interval based on B-cell repopulation, based on ensuring that there's no hypogammaglobulinemia or other infections, etc. happening, and in the steroid resistance at 6 monthly intervals, managing to get off steroids and CNI entirely with this. While this works out beautifully with 90-95% of kids staying in remission for 2 to 3 years, there are consequences, not small consequences. Sometimes you end up converting a kid of nephrotic syndrome to a Bruton agammaglobulinemia with severe hypogammaglobulinemia. So you have to be careful with all these agents. B-cell depletion is not without consequences. There are risks of reactivation of infections and other consequences that I'll come to. But it's come to stay. Now it's being used also in CNI-resistant nephrotic syndrome as an add-on to CNI at about 6 months. Some data is beginning to say that even earlier. But please, this is not good data. This is the survey-based kind of practice decisions. And we need RCT evidence to be sure where rituximab stands in CNI-refractory cases. Less common adverse effects that also need to know about are some of these just listed on the slide. And infusion reactions remain the most common adverse effect that we need to worry around. With all these monoclonal antibodies, now rituximab is a chimeric antibody, meaning to say it's got a mouse component and it's got a human component. So it tends to have more infusion reactions than say obinutuzumab or say ofatumumab. Ofatumumab is completely humanized. And this is again based on what reactions they elicit in the body when they are doing B-cell depletion, which is shown graphically here, and the consequences of complement activation, etc. Now there's some data that's emerging about ofatumumab, that is the completely humanized B-cell antibody, which can work not just with less infusion reactions, but probably with better efficacy than rituximab when rituximab fails. Again, not great data, small data set.
How strictly do you want us to monitor the time?
I managed to run through, so I don't see too many slides. Around 2 minutes I showed.
I think more than completing this slide, maybe it is a good idea to
discuss,
ask for questions, and I might want to start off.
Sure.
The first one. You showed us huge amount of research and huge amount of drugs that people are using in nephrotic syndrome. And if you are an authority, then you can get away with using anything without previously knowing what is likely to happen. Now, is frequent relapse in nephrotic syndrome a single disease or multiple diseases? That's my first question. So therefore, when it comes to that, you can either pick the kind of drugs that we have, steroids and CNI, and whichever CNI comes to the fancy of that particular drug, and then rituximab, and then more mAbs. But do you have anything by which you can say that this child is going to become frequently relapsed? And is this something quantifiable and treatable with different.
So one thing first, that we don't think it's many diseases, we think it's one disease, frequently lacking nephrotic syndrome. I would like to think of it, say, as asthma. Some kids have mild intermittent asthma, some have moderate intermittent, some have severe intermittent. And you scale up your therapy not for everybody at the beginning. You step up as the time goes by and you realize that this child is not getting better on one and you need to go to the next step of care and the next step of care. Because this is a decade-long disease, so one would not be eager to treat with the most potent agents at the beginning. We would want to go gently and we would see if the child does well on just that much and the disease gets better with that. So kids with nephrotic syndrome who start out younger, below 3 years of age, are more likely to be frequently ill. There is some suggestion that maybe South Asians have more frequent relapses than their Caucasian counterparts, even when they are residing in the Caucasian countries, which indicates it's not about hygiene alone. It's about other factors also.
I also not all that, but what is the research to say that is the frequent relaxation in different antibiotics, different circulating factors, different factors than those who are.
There is no such data.
Yeah,
there is no such data. We need to generate that data. That data has not been generated.
Okay. So there are a couple of questions. First question to the PG and then the reporter. If the PGs already know everything, then Aditi has done.
If there are any questions, we can take it.
No, I'm saying that the first frequency questions is the PG.
That's why I'm going
back.
Okay. So give them a mic, is it?
Any questions?
No, they know everything.
This is the opportunity to ask the question where it provides us with guidelines, right? I have a question, ma'am. Are there any genetic nephrotic syndromes which respond to other therapy, medications like CoQ deficiency, and how do you treat? Because we had
these are very rare events, but there is some data to suggest that patients with CoQ pathway defects, there are 4 genes that are described, they would be constituting like 5% of the monogenic lot, and monogenic itself is maybe 10% of steroid resistance, and steroid resistance is 10% of nephrotic syndrome. So those people respond to CoQ cocktail of therapy, and with partial remission being achieved in the majority and good kidney survival. Other than that, there is not great data on anything else. With many genetic forms, people have reported partial response to cyclosporin, and it's been hypothesized that cyclosporin stabilizes the phosphorylation of synaptopodin in the podocyte. But leave that aside, partial remission depends on how it's described. If it's described just by lack of edema and 1+2+ proteinuria without quantifying it or looking at serum albumin, probably it was already non-responsive. WT1 is in particular, even we have reported partial remission, and definitely CNI is reduced proteinuria in a non-immunosuppressive manner also. So in monogenetic disease, some reduction will be expected with CNI, but it's not right to give it because it will also induce damage and the monogenetic is anyway going to. There is some data on ARGDIA responding to eplerenone, one paper, not more than that.
In steroid-resistant nephrotic syndrome, should we wait till genetics is available for biopsy? Because if genetics comes out positive, is there any role of doing biopsies?
I think the other way around. There is far more yield coming from biopsy than coming from genetic disease. Genetic disease is very context-based, useful. It's useful in context of family history, syndromic appearance, and infancy onset disease, where biopsy is more invasive and genetics is better to do because higher yield, 60-70% yield is there. Other than that, one would go for biopsy first. Yes, there is some argument by some people that do genetics first, but then if you were to put together all the data, genetics yield is 10-15%. Biopsy you must have anyway.
And what that biopsy will change?
It will tell you sometimes a membranous, it will tell you sometimes an MPGN, an IGA Nephropathy, particularly in older children. It might give you Alport field, then you need to go for the EM there, or genetics. It might tell you the chronicity element so that you are careful with your CNI usage. Those things would be important to know. It's not like the response rates are markedly different between minimal change and FSGS, but there is some suggestion that FSGS would have lower outcomes in terms of complete response as well as kidney survival. So we have to be mindful of that when we are counseling families.
Okay.
One last thing.
Yeah. Madam, some of the podocytopathy that have respond better with the selective cyclosporine. What can be the mechanism? Cyclosporine's effect on the podocytopathy.
Yes, but we don't know. Nobody talked about TAP effect or not on podocytes because I don't know. I know that there is that 2009 paper which talks about pyrethrocoline civilization by cyclosporine, but not much later afterwards. Other than that, I'm not aware of any data. Neither does data say that TAP does not do the same because nobody has looked at it. I guess. I don't know.
Due to Aditi,